Hello to everyone who is logged on to the COVID-19 health policy briefing. We will be starting in just 1 minute. Okay, let's get started. So hello and welcome to the COVID-19 health policy briefing webinar hosted by the Division of Health Policy and Management at the University of Minnesota School of Public Health. I'm Ezra Goldberstein. I'm an associate professor in the Division of Health Policy and Management, and I'll be moderating today's briefing. We're delighted to be joined today by a fantastic lineup of panelists. And I'm going to introduce them now very quickly. First, we will have Eva Enns. Eva Enns is an associate professor here in the Division of Health Policy and Management. Dr. Enns is an expert in infectious disease modeling and has been co-leading the coronavirus modeling for the state of Minnesota. She will be discussing issues around COVID-19 modeling and predictions. Next, we'll have Abigail Wozniak, who is a labor economist and is the director of the Opportunity and Inclusive Growth Institute at the Federal Reserve Bank of Minneapolis. Dr. Wozniak was previously a senior economist on the White House Council of Economic Advisors, and Dr. Wozniak will be discussing the labor market situation related to COVID-19. Then we will have Lynn Blewett. Dr. Blewett is also a professor here in the Division of Health Policy and Management, and she is also the principal investigator of the State Health Access Data Assistance Center, or SHADAC. Dr. Blewett will be discussing issues around health insurance coverage. Next, we will have Nathan Chomilo, who is a pediatrician and internist and is the Minnesota State Medicaid Medical Director. Dr. Chomilo will be discussing issues around COVID-19 and healthcare for low-income populations. Then we will have Meena Seshamani. Dr. Seshamani is a head and neck surgeon, has a doctorate in health economics, and is the vice president of clinical care transformation at MedStar Health in Maryland, Virginia, and Washington, D.C. She was previously the director of the Office of Health Reform at the U.S. Department of Health and Human Services. Dr. Seshamani will be discussing issues currently facing healthcare delivery systems. Then we will have Scott Kiefer, who is the vice president for public affairs at Blue Cross Blue Shield of Minnesota. Mr. Kiefer has extensive health insurance sector expertise and was previously vice president for public policy at America's Health Insurance Plans. Mr. Kiefer will be discussing implications of COVID-19 for health insurers along with responses from insurers. And then finally, we will feature Kristen Wakelius, who is the senior policy director at the United States of Care. Ms. Wakelius has extensive health policy experience, not only at United States of Care, but also working at the Office of Legislation, at the Centers for Medicare and Medicaid Services, and also as a health policy staffer in both the U.S. Senate and the U.S. House of Representatives. Ms. Wakelius will be discussing issues around state and federal policy responses to the COVID-19 crisis. Our format for today will be that each panelist will have 5 minutes to share their initial remarks. Then we will move to a moderated discussion among the panelists. For today's webinar, we won't be doing any direct audience question and answers. If you do have any questions for the panelists, you can tweet them with the hashtag that you see on the screen right now, hashtag #UMNCOVIDPolicy. I cannot promise that we'll get to them, but we will try our best. So with that, I would like to pass it over to our first panelist, Dr. Eva Enns.
Thanks, Ezra. So hi, everyone. Thanks for joining us. Today, I am just addressing the issue of COVID-19 modeling, some of the challenges that we face and some of the insights that we've found thus far in our work. And so I think modeling has been publicized a lot and present in the media at a level that hasn't been seen before. And you may have heard of the so-called SEIR model, which is the basis of our Minnesota model, as well as many other models that are being used throughout the country and globally. And so the SEIR model is essentially a model that tracks individuals through their progression of disease from a susceptible state, that's where we all start because we've never encountered this virus before and we have no immunity. People who become infected then transition to an exposed state. That would be where someone doesn't have symptoms yet. And then there's a question of whether or not there's any transmission that can occur there. Then to the infected state, that would be someone who is symptomatic, though the severity of symptoms, of course, can vary. And then when someone kind of recovers from the infection, then we put them into a recovered state, and there's an assumption that they have immunity, and so they can't be reinfected, at least not in the short term. And next slide. So in addition to that, we're also tracking healthcare resource utilization, because of course we've seen many health systems in a variety of contexts being overwhelmed with the need to provide care to patients. And so we have some fraction of infections that will require hospitalization, including ventilation and ICU care. And the next slide. And then of course, in addition to that, patients who require healthcare, some of them will recover and have immunity. And then we're also seeing a fairly high rate of death among hospitalized patients. And so we're tracking all of these things. So one of the challenges that we have, next slide, is that we don't actually measure very well the people who are in those susceptible, exposed, infected, or recovered states, because we have fairly limited capacity for testing thus far in the US. And so we don't necessarily have a good handle on how many people are currently infected, how many people currently have immunity, though there have been some recent studies that have come out this week. And so what we're primarily observing are those hospitalizations and deaths that are occurring from the infection. So a lot of our modeling is trying to infer from the observed deaths and hospitalizations what's going on with the underlying epidemic and infectious disease dynamics. So that creates some challenges in terms of data needs for our model. Next slide. Additional components that are challenging and remain uncertain at this time are going to be the role of asymptomatic infections. So even with testing of, say, symptomatic people or monitoring of symptoms, asymptomatic infections are people who never develop symptoms. And there are many infections for which asymptomatic infections exist. And those are people who could be silently transmitting the infection, but wouldn't be detected unless you were doing really broad scale screening. And so that represents a challenge for management, as well as a challenge for modeling if we don't have a good handle on how many people in fact have asymptomatic infections. And there's also a question of, again, that pre-symptomatic transmission. So how much transmission is occurring before symptoms emerge, even among people who do have symptoms. Next slide. And so the insights that we gain from modeling, there are many different models out there, the specific predictions differ, but I think the general trends that we're seeing are actually fairly consistent. So we're seeing in the short term, social distancing limits infections and keeps healthcare demand low, right? That's that flattening the curve that we've all heard about. But the issue there is we've flattened the curve. And so then if we're considering reopening social activity and contact between people, we still have fairly low immunity. There aren't very many people in that recovered category. And so the population remains largely susceptible. And so in the long term, if we look at if or when social distancing is lifted, the infection spreads just as before, okay? And so really the key is to make use of the additional time that's gained by social distancing and things like the stay-at-home order that we've seen in many states. And so that could be in categories of capacity expansion, supporting sustained social distancing for vulnerable populations, as well as reduced social distancing in places that will reopen, and gains in scientific knowledge suggest that we will understand the disease better, we will understand how to manage and treat the disease better as time goes on. So really that's, I think, the key takeaways that we've seen from the modeling, even if when the peak occurs and how large that peak will be is different among different models. So that's what I've got to present today.
All right, thank you very much. Next, we are going to move on to Abigail Wozniak.
Thanks, everyone. Thanks particularly to the hosts and panelists and everyone else joining us today online. So let's just go to the next slide right away. I want to start with just a little bit of a caveat. As you saw, I'm from the Federal Reserve Bank of Minneapolis, and we are in a week that is close to a Federal Open Market Committee meeting, which means that Fed employees are often more careful than we even normally are in talking about what we might expect to be coming in the future. And so today I'm going to confine myself to talking about what we know today from our official statistics about where the labor market stands. And I'm going to put that in a little bit of context for folks. But I won't be able to spend much time at all talking about what I expect to be happening in the next weeks or months. So I think it's not a surprise to folks that unemployment has rapidly soared, but I want to provide some details about exactly what that looks like already. And I also want to emphasize how much of this is not likely to be reflected in our official statistics yet and explain why that might be. So we have really two ways right now to be measuring unemployment that have come in the short amount of time that we've been under significant movement restrictions. And the first of these is something called UI claims, and you may have heard these numbers in the press. UI claims simply means that these are new folks who in the last weeks have filed for unemployment insurance through one of their state systems. And when I drafted these slides, we had 4 weeks of information on that. Back to the second to last week in March, we now have 5 weeks. Over 4 weeks, 22 million Americans filed new unemployment insurance claims. And with the measures that we just got yesterday, that number has risen to 26 million. You sometimes see other slightly smaller numbers in the press as well. I put one of those in parentheses. That's just simply due to some adjustment we do for seasonality in the statistics. But as you can see from the context that I'm providing, it really doesn't matter. Compared to the types of claims filing levels that we have seen in the past, we are simply at a completely unprecedented point in our labor market's history. Over all of 2019, the monthly average, the number of new UI claims filed per month in the country, averaged 218,000. And in the years of the Great Recession, the monthly average, again, over a 4-week period, was 500,000. And so we're simply completely off the charts in terms of the number of folks flowing into that unemployment system through those measures. The other measure that we have right now is an official unemployment rate. This is something that is reported every month in the press. I think folks watch it a lot. It's based on surveying folks around a particular week each month. And so the latest number that we have covers March and surveyed folks on the week of March 12th. So that means that the last time we measured this, again, this is the official unemployment rate, because numbers of folks who file for UI claims may or may not formally move into unemployment due to various kind of technical definitions. But our overall unemployment rate for March, even though we measured it just at the very beginning of a number of shelter-in-place orders, measured 4.4%. That sounds low. It was a full percentage point higher than the last measure. And I'll show in a second that that again suggests a significant change already. Again, for more context, and again, I want to emphasize this was just that week of March 12th when we were first beginning to implement social distancing in a significant way in the US. Employment declined, measured by the statistic, by 700,000 jobs. A great bulk of these were in leisure and hospitality. And again, for context, the largest 1-month decline that we had during the Great Recession was a loss of 800,000 jobs. So we will know much more about this when the statistics for April are released on May 8th. But if we go to the next slide, please. You can see already at the very end of the graph, you see a noticeable tick up. That is our March measurement. And again, if you look at the way this series, for the most part, bounces around, you see that that 1 month measure in March already was kind of an outlier from the rest of the series. We had already a very significant change in measured unemployment in March. Again, even though we were measuring only at the very beginning of the shutdown orders. You see that the peak Great Recession unemployment was 10% in October 2009. Again, I won't be talking about forecasts of this. We'll get a lot more information about this when the next rate is released in May. Let's go to the next slide. The second thing that I want to highlight is that although this downturn has been widespread, it has not been evenly shared. So I'm sure folks are experiencing that some jobs are easier to do from home than others. A kind of brighter spot in a lot of bad news data is that already perhaps almost 40% of the workforce was telecommuting prior to the onset of the epidemic. That means there's a chunk of these jobs that potentially can translate fairly readily to home, and we've seen a number of jobs like elementary school teachers transfer to home pretty extensively in the first stages of the shutdowns. What we've seen instead is that the disparities are falling on a sector basis. So certain industries are much harder hit than others, in particular the service sector, which is not a surprise. But in the March data, we also saw employment in construction fall significantly. Some types of folks are overrepresented in these jobs, but I want to emphasize that really the service sector in particular is very large. So many types of folks are being affected by these employment changes. And a kind of final point that I think is relevant to thinking about the disparities is one of the disparities that we're not seeing. So in particular, we're not seeing differences in these employment impacts across states by the extent of their shelter-in-place orders. So I think that may come as a surprise to some folks who are thinking about the economic impact of these orders. It doesn't suggest that they have no impact, but rather it suggests that the contraction we're experiencing is driven in part by voluntary behavior on the part of consumers and is likely to persist potentially in spite of significant changes to those orders. I'll stop there and look forward to questions. Thank you.
Thank you. Next, we have Lynn Blewett.
Great, thanks so much. I'm honored to be on the panel and just a great setup. Thank you, Ezra, for coordinating and including SHADAC. So we've been working as a team with faculty from the School of Public Health, Jean Abram, Ezra Goldberstein, myself, and SHADAC staff to think about what is going to happen with the COVID impact on employer-sponsored insurance. Next page. As many of you know, most of us get our health insurance through our place of employment. The most current estimate is that 64% of all US workers and dependents get their health insurance from their employer, and this coverage varies by industry and by state. As you can see, there are industries that have high levels of ESI coverage: manufacturing, information services, public administration, and then those who have very low levels of ESI coverage: leisure and hospitality, construction services. These rates also vary by state, and it depends on the economy, the distribution of size and type of industry within a state, and also the level of public programs and safety net programs that support the employer-sponsored insurance system. The highest ESI coverage rates in 2018 were for Hawaii, New Hampshire, Wisconsin, and Minnesota and Virginia round out that top list. And the lowest ESI coverage rates are for New Mexico, Florida, Louisiana, and Arkansas. And you can see the range is great, from 58.2% up to a high of 76.1%. Next slide. So as Abigail talked about, there is a lot of us are watching the unemployment insurance claims and tracking the increase that has occurred quite rapidly, up to now 26 million workers who have filed for unemployment insurance. And this is an unprecedented increase, and we're concerned about the decreases. We're concerned about these decreases in job loss and the potential disruptions in health insurance coverage at a time when we have great need for healthcare. So we've worked together as a team to develop what we're calling the U of M Health Insurance Coverage Model, MINHIM, to begin to sort of estimate these disruptions and have a model that we can build on to watch what occurs in the next 6 months to a year. Next slide, please. So our model development is pretty straightforward, and we have a number of documents, including the technical appendix to all of our work on the SHADAC website. You can just go to shadac.org. We have an issue brief, the slides, and technical documentation to go with this presentation. But we estimated the number of people who lost their jobs in the 4 weeks ending on April 11th. So you can see we took a point in time and things are already changing. So just please note that. Then we estimated the likelihood that employee was an ESI policyholder, and we did that by census region and industry. And then we estimated the average number of dependents covered by a policyholder, and then we combined those to compute national and state level estimates. We used data from the Bureau of Labor Statistics from March 2020. We used unemployment insurance claim by industry in 11 states where we had really good information, and we used that to extrapolate to other states. And then we used coverage data from the current population survey. Next slide, please. So our key finding is that we're estimating 18.4 million individuals may be at risk of losing their employer-sponsored insurance. This includes coverage for policyholders and their dependents. It represents a worst case scenario for ESI coverage disruptions. Some companies may keep their ESI coverage for people who are furloughed, and some laid off employees may choose to purchase COBRA coverage. I think that's the next area of research and input to this model is what are the transitions once you've been laid off work or you've lost your job. Where do you go to get coverage? It's evolving as more data becomes available on coverage lost and the impact of the stimulus package to support safety net providers and states to meet the needs of an increasing number of uninsured. Under a worst case scenario, if all of the people lost insurance coverage, and I think as the economy is shut down for longer periods of time, that will be approaching the worst case scenario, that there could be a potential rate of increase of the uninsured by 65% from the current rate of 8.8 to 14.5%, which is getting close to our pre-Affordable Care Act levels of uninsurance of 46.9 million uninsured. So go to our website and take a look at our documentation of our methods. We're open to input. We'd love to hear your comments. We're continuing to work on this model, and thanks again, Ezra and the panel.
All right, thank you. Next, we have Nathan Chomilo.
I echo the comments of appreciating the opportunity to be here and discuss care for our under-resourced populations in COVID-19. So you can go ahead and advance to the next slide. So among the challenges for state Medicaid programs include navigating the paperwork to get approval for program modifications. And so you can see this table on the right is a high-level view of some of the tools states have used, like state plan amendments or waivers to 1915 and 1135 to adjust the different components of the plan that they hope to address. Those in orange show the ones where Minnesota, our program has already taken some action, and they're broken down by different components that you can address. You can advance the slide. Thank you. So, more some of the bigger challenges to the populations we serve kind of really lay in the broader structural barriers they face to not only accessing care, but health in general. And so, the diagram on the right is an analogy of an iceberg, and that really kind of talks to how structural racism works. And there's things that we see and that are explicit, and there are many things that are more implicit. And many of our community members face structural racism, which manifests in less economic reserve due to barriers in access to homeownership and well-paying jobs, having to work jobs that increase exposure versus working from home, increased rates of some of the chronic illnesses that we know increase your complications from COVID-19, and then certainly mass incarceration has disproportionately affected certain communities, which impacts your health. Additionally, there's millions of undocumented immigrants who are often in mixed households where they have legal status citizens living together, and those undocumented immigrants often lack access to public insurance. And there's still just a large number of uninsured in general, and part of it is due to health literacy and the complexity of the healthcare system and just getting enrolled in the first place. And then there's just barriers related to that complexity that we know certain populations face, like those who are seeking mental health services, SUD, or substance use disorder treatment. Certainly have prenatal, maternal, and pediatric primary care populations, and those who receive disability care. Next slide. So when thinking about kind of concerns as well as opportunities, I broke it down into kind of immediate and the aftershocks. And so regarding immediate opportunities, certainly funding for our critical access hospitals and other Medicaid providers is really crucial, particularly pediatric primary care, which we know is really hurting right now. Public charge rule still continues to have a chilling effect, and so even if we are able to broaden access and coverage, will people show up and take advantage of that due to fears of its impact on the public charge rule? Reaching populations with limited English proficiency is a big concern. They're just at increased risk, and we actually know, looking historically back at 1918 influenza pandemic, the H1N1 influenza pandemic, that those populations had worse outcomes, and so trying to address that. And then thinking about the guidelines that we're using. So the colorblind aspects of some of the guidelines that have been published in the New England Journal of Medicine and JAMA around scarce resource allocation, not taking into account the pre-existing structural inequities and how if we don't address that, we will be perpetuating those, and looking at the testing guidelines even for COVID and how those would manifest the same way. When we look at aftershocks, again, looking at our response, if we aren't thoughtful about the structural inequity that currently exists in our response and address that on the front, we're just going to continue to perpetuate that and see worse outcomes. I worried about telemedicine seen as the kind of panacea and a lot of investment going there, but not really recognizing that not everyone has telephone access, not everyone has video access, not everyone has the literacy level to set that up. And so making sure that we don't get blinded by looking just at one option that seems like a low-hanging fruit. And then the real concern that the economic crisis leads to cuts to other social services that then impact health. Next, advance the slide. So this is a really nice kind of way to look at the aftershocks, and it looks at the first wave being the immediate mortality and morbidity, the second wave looking at the impact of resource restriction on urgent and non-COVID conditions. And so say you have things like strokes and heart attacks that are happening and we don't have the same level of care available to them. The third wave is the impact of interrupted care on chronic conditions. And so those who do have things like diabetes and hypertension, they aren't getting the care, routine care that they usually would get right now. Do they show up with more complications down the road? And then the fourth wave, certainly looking at the psychological and social impacts, PTSD, and then the economic impacts as well. Last slide. Sorry, next slide. So what's giving me hope? For now, the ACA is in place, which is something we didn't have back in 2008. There has been some increased federal funding. I'm hoping for more, particularly for Medicaid providers, and at least one state has proposed targeted relief for Medicaid clinicians. The opportunity for cross-sector collaboration and looking at data to make a stronger case for addressing social drivers of health. And then really this idea of building equity into the walls. And there's a lot of times I've heard the analogy that we're kind of building the airplane while we're flying it. And certainly equity is something that's been talked a lot about in these spaces. And now is the time to really put that front and center and not just say that we're only going to talk about it when it's easy, but really how do we restructure and build that into the walls. And so I like this kind of tweet that kind of really captured that, how normal wasn't working for many parts of our population. And so both as we're building it, as we look at moving forward, we should not be going back to the way things were. We really need to kind of continue to do better going forward. So I look forward to questions. Thank you.
Thank you. Next, we have Meena Seshamani.
Great, thank you. If you can advance the slide, please. So thank you. I want to echo the thanks for having me present today and engage in discussion. So first, I am from MedStar Health. I lead clinical care transformation. This is a 10 hospital health system with 300 outpatient clinics, urgent care, visiting nurse association, residency program in the greater DC area. So, you know, business had been going on as usual. Next slide, please. And then enter COVID-19. I think two key points that I have been reflecting on in helping to lead the coronavirus response for our health system is that changes that have occurred in our health system prior to the pandemic have enabled us to better respond to the pandemic, but these changes have not been enough. And there are lessons learned which should lead to improvements to the system when we emerge on the other side. And what I'd like to do is just walk through a few of those with you today. Next slide, please. So I'm going to kind of break it up into 5 areas for impact, some of which have been touched upon by prior presenters. So first, looking at health insurance coverage. Certainly, many more Americans have insurance now compared with a decade ago, but these situations are changing, as others have noted on this panel. Millions remain uninsured, and also millions more are underinsured, where they still have high out-of-pocket costs. And this is all coming to a head where if you have people who are hesitant to seek medical care because of the high cost, in a public health infectious disease crisis, those delays in seeking medical care can equal viral spread and death. And so it's increasingly important for us to examine the types of health insurance coverage that's available for people, how it can be available in a simpler, easier way to understand so that people can purchase the type of health insurance that best suit their needs. Next, public health infrastructure. So I think it goes without saying that if we've learned anything from the current pandemic, it's that our public health infrastructure was not adequately prepared, resourced, or integrated with the overall healthcare system. So lack of capacity around testing, contact tracing, and containment blossomed into a lack of capacity for hospital beds, ventilators, staffing, and personal protective equipment for healthcare workers. So certainly there's a lot of opportunity here moving forward, and we must do it quickly moving forward, particularly if we want to be able to reopen the country in a thoughtful and sustainable way. But I think with both of these first two, they should be viewed with an eye towards what are things that should be done downstream in the healthcare infrastructure with our healthcare system, what can be done concurrently so that we're addressing this issue in a more holistic way. So moving to quality and value in healthcare. At a time when our country needs our hospitals, doctors, and nurses the most, the COVID-19 crisis actually threatens their very ability to continue to provide care because they work in a system that needs fee-for-service elective procedures to be able to stay afloat financially. So this really is a clarion call for value-based care arrangements and care models that encourage primary care prevention, care coordination, where you are rewarding for keeping people healthy and for containing costs in healthcare. And this is even more important when you're dealing with a public health crisis where providing care within the 4 walls of a hospital, you can care for a COVID patient, you can discharge them, it's wonderful. But if you don't address the needs after that patient leaves the hospital, where they have to continue to isolate, where they could decompensate, you will be left with continuing viral spread and potential decompensation and revisit to the hospital and untoward circumstances. So really being able to engage in this more holistic approach to how we provide care for patients is going to be critical moving forward. This ties into social determinants of health, which the prior panelist also mentioned. I think we all have seen in stark relief how low-income and African-American populations are being affected by COVID-19, and it really brings to light how health-related social needs and socioeconomic situations dovetails with what ends up happening with their health. So again, take the example of the COVID patient who now needs to be on isolation. How do they obtain food? Do they have a caregiver who can help them? Are they able to effectively isolate in their house to avoid others from getting ill? This is an opportunity where health systems are working to really integrate clinical interventions with screening and interventions around social needs, linking with social support services in the community, because otherwise you can win the battle of that COVID patient in the hospital, but you'll lose the war. So this area also is very important for future work. And then finally, telehealth, which again was mentioned. Telehealth is not a panacea. I would echo that. Telehealth is particularly important when it's paired with models of care that can leverage it to provide better care coordination, better access, better integration of care. To give an example, we have been using telehealth where we can support our skilled nursing facilities in our areas, which have some of the most high risk and frail populations for COVID-19. Being able to leverage telehealth in that way so that really addressing the population needs of the population, and also how we leverage health information sharing and electronic medical record interoperability as a result is also important. So thank you for the opportunity, and I look forward to the discussion.
Thank you. Next, we have Scott Kiefer.
Good afternoon. Thank you, Ezra, and thank you for the opportunity to join everyone today. I really appreciate being with such a great group. I'm going to sort of divide my remarks into where we've been up until this point and where we might be going. I think that we're obviously in a big pivot. I would say that as we think about the federal government providing some resources, $25 billion in the package that passed the US House yesterday, we're really in this place of public health surveillance and testing in the economy. So one thing I would suggest from our perspective, if you could move to the next slide, please. We're very concerned that the conversation about the economy is getting a little bit ahead of the science, and that's particularly true on testing. So I'll talk about that in a little more detail from a health plan perspective. But I want to start with where we've been from a planning standpoint and an engagement standpoint, and take you back to March 6th when the disease was really first emerging in the United States. And fortunately, we had done a lot of planning from a business resiliency standpoint, from engaging stakeholders and the provider community standpoint, and also thinking about our members. So mindful of those barriers to access and the cost implications, and not wanting people to see that costs were a barrier to getting testing. On March the 6th, we announced as one of the first plans, I think, in the country, that we were going to be waiving cost sharing for treatment. So essentially treatment would be available for free for all of our members. That formed the foundation of sort of our mission focus on what we needed to do to be supportive of the pandemic. We had a number of subsequent announcements, including, as has been discussed, flexibility on the telehealth side. We were very mindful of the inequitable nature of telehealth and the fact that, for example, under existing rules, telehealth actually required a video visit, which is why one of the things that we supported regulatory flexibility was to allow even a phone call, recognizing that most Americans at least have a phone if they may lack a computer or internet access. Ostensibly, that was all designed to create provider capacity so we could support our health system partners in planning for what we knew was to come. We've followed those announcements with acceleration of payments under our quality program and our quality pool, such that about 2 weeks ago, we announced that we were advancing $80 million of payments that generally are issued in fourth quarter in the October-November timeframe. We were just going to pay those out and assume that all the health systems and our provider partners were meeting their quality targets and incentives for the year. We had a lot of great action as well at the congressional level, and several bills passed. Those were rightly focused on the economy initially, but as Dr. Blewett described, we're very concerned about the rising impact and potential for the uninsured. We're also very concerned about the inequities that are emerging and how those are really presenting themselves as a challenge we have to face in the here and now. To supplement the work that's been presented that SHADAC is working on, we were very influenced by a health management associates analysis at the national level that suggested very early on, consistent with the 18 million that was cited earlier, that we would see a reduction potentially of roughly 10 to 30 million in the out case scenario based on unemployment. And I would tell you that regrettably, we believe that we could be unfortunately close to that 30 million range. So to move forward under the next grouping there in the emerging issues, as I mentioned, public health surveillance is emerging as sort of the issue in the economy, both here in Minnesota, terrific collaboration that Governor Walz and the U obviously is involved in that, as Mayo and other partners this week. But I want everyone to understand that there's a bit of a sordid legislative history in the establishment of testing, in that non-FDA approved tests have to be paid for and provided. So there's been a proliferation of tests, many of which are low quality. That's an issue we have to think about and pay attention to. With respect to the health coverage issue and the unknown cost impact, I do want to say that I agree that it's important to take action on the COBRA side. What we're supporting is a COBRA subsidy that would be available to workers at 100%, so we wouldn't lose all those individuals with employer-sponsored insurance. There's another related unknown that is tied to Congress's response in this economic downturn, and that is the issue of the $600 supplemental payment, which was provided to unemployment insurance. So we're going to see a number of individuals that normally would be readily eligible for public coverage that may not because of that $600 payment. So that's an issue. And then finally, just to tick off those that we see below, privacy is one emerging consideration in the contact tracing. Some of the issues that have been brought forward related to healthcare, obviously privacy is a very sensitive issue. The lasting impacts of behavioral health is something we're going to have to account for. Essential workers in the long-term economy, I believe that we need a reevaluation of the basic employee-employer relationship, probably in a way that we haven't thought about since the Fair Labor Standards Act in 1938. And then, of course, the long-term planning. What frustrates me as a former congressional staffer, being on Capitol Hill as a congressional aide after 9/11, is that we made a lot of adjustments, but the reality is what we spend from a counterterrorism standpoint dwarfs what we spend as it relates to bio-incidents or pandemic planning. So that also requires reevaluation. So thank you again for the opportunity, and I look forward to the questions.
Thank you. Now we move on to our final panelist, Kristen Wikelius.
Great, thanks so much. It's great to be here, and I've really enjoyed everyone's remarks. We'll go to the next slide. So for those of you who don't know, United States of Care, we're a new organization founded a little over 2 years ago, aiming to build a path forward towards a new people-centered healthcare system that works for everyone. And our work is really guided by 3 key principles. We'll go to the next slide. As we focus on our response to COVID, we're seeing that the pandemic has exposed and exacerbated many of the fundamental flaws and challenges in our health system that many of us were already working to address. And as we've been talking with states and advocates and people, 4 key themes are surfacing which can help guide the federal and state policy response. First, people really want to make sure that they have accurate information and recommendations on the virus and what they need to be doing to be healthy and safe. And second, people want to know that the healthcare system is going to be there for them. They want to know that it's adequately resourced, it will be reliable, and that that's true both during COVID and then afterwards. And third, we're hearing that people are really worried about the personal financial impact of the pandemic, and they want there to be clear and dependable support for them and for their families, both financial and medical well-being. And finally, people understand the disparate impacts of COVID and the fact that some of our friends and neighbors are at higher risk. And people want a system that's going to respect and value human life and takes care of the people that are most vulnerable. So there have been a lot of notable and important policy steps taken along the lines of these goals, many of which the preceding panelists have mentioned, especially with the 4 pieces of legislation that Congress has already passed. We're also seeing a lot of really robust state responses through Medicaid waivers, which we've heard some about, the loosening of regulations around licensure and telehealth to promote access, and states that run their own marketplaces creating special enrollment periods so people who need healthcare coverage can enroll. But there's also a long way to go in meeting the needs that people have and many of the public policy challenges that people have already discussed. I'll touch really quickly on a couple of interrelated challenges and then close with a reason that I think we can be hopeful. First, we've seen Congress respond really quite quickly in terms of what we've come to expect in this age of federal gridlock, though they've consistently left work to do in the bill that will be quote unquote next. So a great example is the $25 billion investment for testing and related activities that Congress just cleared this week. That's a great investment in building important public health infrastructure, but already it's possible that that might not be sufficient to build the large-scale force of contact tracers needed to follow up on testing results, and then also to provide people with the help and the resources that they need to safely isolate and quarantine. We're seeing then that the political lift of getting legislation through has become increasingly challenging with each subsequent bill. So we run the risk that eventually the next bill that has important priorities won't get done, especially as this public health crisis drags on and the political pressures of an election in November get closer. So that brings me to the second challenge I'll touch on, and that is the increasingly dire fiscal situation that states and localities are finding themselves in. Our states are truly on the front lines of this public health crisis, and they need to launch and sustain comprehensive responses that require expansions both in their public health capacity and infrastructure, all while they have to shore up their safety nets to meet many of the needs that we've heard about. And at the same time that states are being asked to do this, they're facing budget shortfalls that could be as much as $500 billion over the next 2 years, and even short-term cash crunches that come with delayed tax filing deadlines. So states won't be able to be successful in doing what needs to be done to control COVID for the next 18 months or more if they're forced to make budget cuts, lay off key personnel, and plugging these gaps ultimately will probably require ongoing federal support that Congress may grow increasingly unwilling to provide. Despite these long-term challenges, I'll close quickly with one reason to be hopeful. And we're certainly hearing that people want to make sure our system is taking care of those who are most vulnerable at risk. And what we're seeing is that COVID is forcing our health system into some remarkable cross-sector collaborations at the state and local level that certainly, while addressing COVID now, are getting to the heart of long-standing healthcare issues that our system has needed to address. One example that US of Care has profiled is the New York City Rapid Response Coalition, which came together in March with the goal of supporting at-risk populations with underlying chronic conditions. This group includes providers, payers, social service organizations, and companies like HelloFresh and Uber that organized around the principles that putting humanitarian efforts first and self-interest second to the communal need. They've quickly launched a pilot that's facilitating providing care, food, supplies, and social services to a cohort of New York City residents most at risk from contracting COVID or experiencing non-COVID related health complications that could strain the overburdened healthcare system. And really the needs that this group is addressing, connecting people with basic services to keep them out of the hospital. This was a need and a challenge that existed before COVID and will continue to exist after. And the explosion of COVID in New York City really created the impetus to put the needs of the community first and to build partnerships that otherwise could have taken months to come together or perhaps not happened at all. If you're interested in learning more about this particular model, we have a playbook and a case study available on our website at United States of Care. But we think this is a great example of the type of innovation and collaboration that will help overcome the pandemic in the short term and then improve our healthcare system in the long term. So thanks again. It's great to be here, and I look forward to the discussion.
Okay, thank you, and thank you to all the panelists. So now we're going to turn to some Q&A discussion across the panelists. I will note that we have gotten a number of actually very terrific questions on Twitter at our hashtag, and because we are a little short on time, unfortunately, we won't be able to get to them. And in fact, we won't even be able to get all the questions that we had for each other. So let me start out with one that is a sort of a large question that I think is well suited for a number of our panelists, and it has to do with healthcare financing given our current situation right now. Some panelists have alluded to how the Trump administration has taken, and Congress and the Trump administration have passed legislation, and there have been promises from the Trump administration that there will be money for COVID testing and treatment for people who have uninsurance. We have heard about how, in the example of Blue Cross and Blue Shield, how they have done advance payments to some of the providers in their networks. When we think about how we're going to be paying for healthcare given this sort of unique combination of stressors to the healthcare system, what have we done that's good, and what else do we need to be doing both from the public sector perspective and the private sector perspective, including insurer perspective? And I think, please feel free to jump in, panelists, because I think a lot of you will have good ideas about this.
So, I mean, I can kick it off. This is Meena Seshamani again. So, you know, I think that providing, you know, what the Trump administration was saying is covering the cost of COVID treatments for uninsured hospital treatments at Medicare DRG rates. You know, absolutely, is that helpful? Yes. However, I think it does create confusion and doesn't necessarily address the underlying issues of what the lack of health insurance actually means for people being able to get care. So, for example, if a patient had COVID-like symptoms, came into the hospital, they were very sick, but they were very sick with the flu, it turns out not COVID. Then are they stuck with the thousands of dollars of hospital bills? And is that something that would make someone think twice before they came into the hospital, even if they were very sick? I think you still end up with that dynamic. And to carry it forward, say someone's in the hospital, say they have COVID, say they get better, and they're gonna go home, what happens for all the care that needs to happen after they go home? I think, you know, as has been reported, there are people who need to have home oxygen after they go home, nebulizer treatments. If they have other underlying chronic conditions, those can be exacerbated by this acute illness that they had. And what happens with all of those treatments? Are they covered? Are they not covered? I think that there's still a lot that remains to be done in that regard. And this is where I think policies that will look at health insurance coverage in a more holistic approach is going to be important, rather than just from the, let's just try to address this right now with COVID specifically.
Hey, Ezra, it's Scott. I'll jump in. I would just say and agree. We agreed to cover treatment, first dollar, no cost share. I think one of the things we're very concerned about, given that there is no approved treatment for COVID, we have no idea what those treatments, we have no idea what Gilead may do, for example. They have a drug in clinical trial, what that drug could be priced at. We have no idea what a vaccine might be priced at. So that's a big concern. I mentioned the testing issue. The testing issue is really important because right now there's no barometer on what testing could cost. And we've already seen examples in market of serology tests being set at $600 or $800 a piece. And those are mandated to be covered right now. So we think that there needs to be a real coordinated structure, which is why it was such a welcome announcement that the governor and others, as I alluded to this week, sort of took the reins of wrangling that in Minnesota. But I agree, these issues related to cost and ultimately someone's going to be paying. So I think it's really important to do our best to try to hold people where they are from an insurance standpoint, which is why the comments about the next congressional package and my comments around a COBRA subsidy, given the work that Lynn presented and you've been involved in, I think is so important that we don't increase the ranks of the uninsured.
And this is Nathan. One thing I'll add to that is what was welcome in some of the federal increases in FMAP was a requirement that you really couldn't kick people off of their state-sponsored and federal insurance. And so continuing to look at ways to increase and ease enrollment and eligibility, presumptive eligibility, that changes that can be made to allow people to more commonly get on insurance, I think would be welcome in this space, and kind of continue to mirror the kind of public health response with actual policy that supports the behaviors and hopes we have for people getting the care that they need.
Thanks. So I'm looking at the time again, and we really have just a few minutes left. So I want to pose sort of an open question for the panelists, which is that based on the issues and the trends that you've all identified and you've all discussed, if you had the ear of some decision maker, whether it's United States Congress or state legislators or governors, what would you say is the most important policy priority or need that you would identify them in their next round of action?
I'm going to jump in quick because I have to leave promptly at 1, but I will just continue to stress the need for Medicaid specific funding. A lot of the initial funding went through Medicare, and our Medicaid providers who are already operating on slimmer margins really will continue to need some increased funding avenues, whether it's advanced payments or other ways to increase the rate that we can use to increase the rates. I think that's really critical going forward.
And I would certainly agree with the importance of making sure that providers, especially those that serve Medicaid populations, are able to be there when it is time to open back up. I think in terms of overall priorities, as I noted before, making sure that states have the resources, not just immediately, but longer term, both to make sure that they're able to make the public health investments that they need, and then also invest in particular safety net programs to support people for the next year, year and a half with food, social services, and other needs is going to be really, really critical.
Yeah, and I will add that I think that initially in the first wave of support packages, there was a real spirit of moving away from targeting and trying to roll out really broad programs, not spend a lot of time and cycles trying to think about how to finally direct resources to those who most need it. But I think the second wave of policies will need to think about improving that targeting. Some of the broad approaches we've seen have had some unintended consequences, like Scott was alluding to, potentially the negative interaction of the $600 benefit with later health insurance coverage. So a kind of mindset of it's time to think in a more targeted way while retaining some flexibility and certainly enough resources to cover everyone who needs it. I think that needs to be really very much the spirit of the next wave of proposals.
I would just add on the ESI coverage and the potential disruption from the COVID of people losing their jobs. I think one of the Twitter comments that I've been following was for the Congress to think about picking up COBRA financing for people who are losing their jobs and think about strategies to keep people insured who were insured through ESI. Open up healthcare.gov for special enrollment period. Add to the 6.2% FMAP that states got. I know a lot of the governors were advocating for an additional 6% that can be directly channeled into the safety net. And then education and outreach for the safety net programs and what exists and what's available to the insured and the uninsured.
You have time for one last quick thought if anyone who hasn't spoken up yet has anything to add.
What about you, Ezra?
As a non-clinician, I would just say that we really need to go to the science, and I think the testing considerations, that's real important. And I think that in hindsight, it probably was a mistake to mandate in statute that non-FDA approved tests had to be paid for, because I know our clinicians and our chief medical director is very concerned about the number of tests that are out there and may be unreliable. And that was actually a situation that contributed to spread in Italy and Spain.
Yeah, and this is Meena. I was going to say the public health infrastructure, I think, is one thing that hadn't been mentioned yet, but I think continues to be important. You know, how do we manage our strategic stockpiles, maintenance of them? How are decisions made about what is allocated? How do we make sure we're doing our tabletop exercises and preparing, you know, so that we can ramp up when needed in ways that make sense and that can address various aspects of where crises end up hitting us in terms of industry and economics, as well as health and social sectors.
Thank you. Okay, well, I'm very mindful of the time and want to be respectful of everybody's time. So with that, I'd like to sincerely thank all the panelists for participating in today's webinar, along with my HPM colleagues, Mona Rath and Emily Engereiser, for helping to make this happen. Thank you to everyone who's tuned in to the University of Minnesota Division of Health Policy and Management's COVID-19 Health Policy Briefing. We hope to do more of these briefings on a range of pressing healthcare issues and healthcare policy issues related to the coronavirus pandemic and COVID-19. So please be on the lookout for that. So thank you for tuning in and stay well, everybody.
Thank you.
Thank you.